Good morning, everyone. Good morning, Ramchandra sir, and Ramesh, and all the other students who are logged in. So it's a slightly different talk, Ramesh, from the one we had given there, because I was thinking hard about what would be appropriate for our students here. And I'm just going to spend a little time on the basics of medical ethics also. So I thought I just incorporated that into the talk. So it's going to be in two halves. The first half will be spending a little bit of time on the components which make up medical ethics, which will help us practically in our clinical decision making and in our counseling, more importantly. And the second half, we'll look at the relevance of that with regard to prenatal counseling, especially because we've had quite a few lovely sessions on prenatal diagnosis. So this is like Ramesh actually wanted it to be like a counter point of view. So the other side of the coin, so to say. Okay, so with that introduction, we go ahead. This is one of the voices of caution because mankind has managed admirably well. From the era of the first imaging, you can see there with the hands, and I think at least when we started off, it was part of our examination tools to have those instruments which would hear the heartbeat and things like that. And rapidly, it has progressed in the last 25 to 30 years from purely hand felt palpatory methods, and still majority of mankind surviving beautifully. They've then moved on to the 2D ultrasounds. You can see the not so attractive black and white image, which is still one of the best tools that has been developed for picking up antenatal anomalies. Then, of course, comes the fancy stuff. If you come to the left lower picture where you have the 4D ultrasound image, and this is the current craze. I also work in the corporate sector, and sometimes they spend hours trying to get the perfect portrait. And these guys are already there. Oh, Dr. Ramchandra is not in the room yet. Someone has to unlock the room. Ramesh?
No, I'm in the room.
Oh, I just got a screen saying unlock.
No. How can I put a message if I'm not in the room?
Correct, exactly. Oh, so you're saying to unlock the room for somebody else.
Yeah, other people will be trying to get in around this time. Between 8 and 8:10, people will be trying to get in.
Yeah. So who will do that? Will you do that?
Done it.
You got it. Okay. I got a little disoriented because I already addressed Dr. Ramchandra, and then he said he's joining the waiting in the room. Yeah. So then came the 4D ultrasound, as I was saying, and especially in the corporate world, I know that the people give a lot of undue importance to these frills of corporate health. And GK Whale is there with a ready frame, and then they're taking this picture of this baby and taking it home. I think, and parents keep going on about wow and all of that. But I'm very glad that for at least for Ramesh and me, our parents never got to see what we look like with the 4D ultrasound. We wouldn't have had a chance. There were centers packing there itself. So, and I want to stress this especially for the youngsters, not to get lost in the frills of corporate healthcare, because this is one of the frills. The other frills, as an aside, is we had a patient about 2 years ago. Normal delivery, absolutely fine baby. And there was a big ruckus outside the lobby of our hospital in Rainbow because there was a big fight going on between the parents and the hospital staff. Because as a corporate package, they always tie these blue balloons for a boy and pink balloons for a girl and put one ribbon around the car. Now, this man had not brought his car, but he had ordered a Ola cab. So the Ola guy was there and he was refusing to have the ribbons tied. And this man was refusing to go without the ribbon and the balloon because he had paid for the balloon, obviously. So this went on for 45 minutes with arguments, with the baby, the newborn baby in their hand waiting in the sun. That is when I realized that sometimes we can get lost in the frills of private healthcare and forget the most important things which are there. And that can happen even with radiology, with the kind of imaging which is there, where we can get lost in the technology. The technology gets better and better. As you can see the MRI on the side there, you can see all kinds of small variations. I wouldn't even call it anomalies. In Bangalore, we've had workshops where people have shown us atypical years, as they called it, and we were curious to see what atypical years was. And it was the Mahatma Gandhi kind of year. And parents were being told, your child's years will be like this. It will be abnormal. And I'm sure some parents may take that as a hint or as a directive, as we'll go into the ethics of directive counseling, to say that, oh, my child's years are going to be abnormal. Should I continue with the pregnancy or not? So today's talk is basically going to be a balance between advancing technology and using that technology judiciously rather than getting very excited. In most spheres of life, whether it was the red line was the industrial age, things always took a slow progress. It started off as a small plateau, and it slowly did a mild slope, and then plateaued off again. Same came with the technology and with the information age. But then, if you see the current age, the one with the black line, in terms of medical imaging, in terms of all kinds of AI, in terms of software, in terms of what comes into healthcare, even the curve is very steep. There is no plateau at the beginning. It starts off with a real steep thing, and therefore, everyone is always on a learning curve, and always there's going to be something new which will come up. And this doesn't allow time for processing in our minds and in our decision making. Because before you mastered one particular thing, the next technology is already there. And this is the voice of caution that is there in across all fields. We have seen this even for nuclear warfare. We've seen it in any kind of technology. And medical technology is exactly the same, because the speed at which it's going is not allowing us to it's not giving us a pause to take a proper decision. I hope today's class for us as pediatric surgeons is just to highlight how we probably need to slow down a bit in our enthusiasm terms for technology. Right. Why is this important? Because as human beings, we always respond differently to what we know in our heads and what we see. The best example of this was the Ethiopian famine, which happened around the 80s, where it was one of the worst famines ever recorded, and millions of people in trouble and dying and starving. And a lot of radio articles, a lot of newspaper articles were there. So a lot of people around the world knew what was happening. They knew there was a famine somewhere in Ethiopia, and that has remained in the consciousness for long. But nothing much came in terms of relief. Till one BBC photographer took a picture of that child who was starving, and there was a vulture sitting next to it, waiting for the child to die. That picture was a very powerful picture that came out in the newspaper, and immediately things changed, because people now not just knew about the famine, but they could see death, and that triggered such a positive response in terms of relief. So there was an outpouring of relief, and it ended up finally with that Action Aid concert raising money for Africa and Ethiopia. So that a lot of psychology journals have studied that phenomenon and saw how just the image, the fact that we can see something, makes us respond instinctively differently, even if we know the same thing by just hearing about it. And this is true for us, especially in fetal surgery. And I'd encourage you to read this article, this Ethical Challenges in Fetal Surgery. It's there at the bottom. I'll email the slides. Came out in 2011, wherein this was analyzed. And I think that is where fetal imaging, where we are seeing ultrasounds and better MRIs and ultrasound showing us small anomalies. Just seeing a small anomaly like hydronephrosis or unilateral hydronephrosis or an atypical ear, as they put it, or even polydactyly. I've had children when I was back in St. John's, not children, pregnant women who have aborted fetuses for the simple fact that they had polydactyly, because the counseling person, the radiologist, opened his textbook and saw that polydactyly has a 9% chance of sensory neural deafness. So the way it is communicated is, yes, your child is fine, but there may be a chance of deafness. And the parents took it as, oh, doctor is telling us that my child is going to be deaf. And if you talk to Dr. Ramchandra, talk to Dr. Ramesh, you'll realize that in practice, even today, even unilateral hydronephrosis, by the time they come to us, the first question in their mind is, my child is having kidney failure. Right? So they interpret based on the direction in which they are counseled. And that is the power that we have. And this is what I want to sensitize to our PGs today. That one, we respond differently. And two, we the urge to intervene is directly proportional to how much more we can see and how we can interpret. And as human beings, whenever we see injustice, we see something wrong, we are unable to help ourselves. Most of the time, we feel obligated to act. It is the innate nature. But in the realm of ultrasound diagnosis, it is becoming a weapon. It is becoming a double-edged weapon, wherein apart from helping, it actually seems to be leading to more harm. Right. So before we go into fetal thing again, I just want, this is for our students. I'm sure you learn it in your undergraduate nowadays. But just to revise, there are 4 pillars of medical ethics that we are aware of. We know this in theory. One, of course, is autonomy. Autonomy here refers to the autonomy of the patient. Autonomy of the patient, not of the decision making, not of the healthcare giver, not of the family. It is the autonomy of the thought of what he is about to undergo, the intention behind it, and whatever action is taken. So, this is the classical definition of autonomy in medical ethics. Obviously, when we come to pediatrics, it becomes a gray zone because then they are truly not involved, but somebody else, by nature of being a child, somebody else will take that. But well, let's go through first the general principles. So, this is autonomy, wherein they're coming in without any other being misled, and their thoughts, intentions, and actions are geared towards that particular treatment. Then, of course, comes the concept of beneficence, wherein we are intent on doing good. That has to be the primary goal of all our treatments. Whatever medicine we give somebody, whatever surgery we do, whatever decision that we make in the medical realm. So these two are the first two principles. Once these two are established, once you have an autonomy and beneficence established, then we have to look at justice. Justice is basically the broad concept is that it's a fair chance, a fair opportunity, and with benefit to all, with burden to none. It's a very ideal definition. That means if I have 10 patients and I have only 4 doses of a drug, then it becomes a problem. That's where the autonomy is okay, beneficence is okay, but justice is difficult to deliver in that scenario. So then it becomes an individual patient scenario wherein it is juggled and said who's going to get the maximum benefit, who is going to benefit less, whose lifespan is long, whose lifespan is short. All of those individual definitions will come. But justice is an equally big pillar which needs to come. When it comes to fetal counseling, it plays a very big part. And of course, we know this above all, do no harm, non-maleficence, where it does not harm the patient, nor does it harm others who are related to the patient. So these are the 4 broad principles. And I think this we should keep in mind for almost all our difficult decision making, not just for fetal counseling. So just autonomy, beneficence, non-maleficence, and justice. These are not mere words, as you will see from the next slide. So when we come to the 4 pillars of ethics in the realm of fetal counseling, that one of non-maleficence actually is very hard to define because suddenly there is a harm either to the mother or to the fetus or to the family. Let's go through autonomy first. Yeah. So autonomy is basically here. There is no real autonomy between the fetus and the mother. It is impossible. It is a theoretical concept to have to say that there is autonomy in this decision making. Because for first reason, the access to the patient itself is through another patient. Remember, your parent also is a human being. And all kinds of imaging, all kinds of testing, invasive testing, any kind of fetal intervention, all of that, you are violating one human being to get to another human being. So autonomy itself is out of the window because then the decision making, which is being made purely by the family and the mother, and as we'll see, sometimes I'll take you through an example where the mother is a different entity from the rest of the family. So the rest of the family will be on one wicket. The mother itself is on another wicket. And the fetus is, of course, not at all in the consideration of the autonomy. So it's a very gray area. It becomes purely theoretical. We can't say that we did a great, proper, standard counseling with autonomy. It is impossible in the realm of fetal counseling. Now, beneficence, yes, this can be argued on a case-by-case basis. Now, if you're having a child who's got multiple complex chromosomal anomalies, And then everyone sits around, it's a team meeting, and they're talking about there should be more good than harm. Is it worthwhile? That itself is a dangerous proposition, because that is the place where we end up playing God, especially with the speed of imaging. I think imaging has reached far faster than where decision making can reach. It has become like a toy. It is like giving an Xbox toy to a really small baby, and the technology is beautiful, but he can press any trigger he wants anytime. And unfortunately, if you look at third world countries like ours, and some other first world countries where regulation is not very great, you will really be correct in using the word trigger happy, because the imaging decides what has to be done. And we know this, especially the reason I mentioned our country especially is because of female feticide in the womb, because we know that there are brilliant ultrasound machines which are portable ultrasound machines which fit into the pocket of people. And in UP and in Gurgaon, they've got small mini vans, omni vans, which are doing ultrasounds. The woman gets in on one side, the car is moving, they determine the sex, and then they stop, and she gets down and then gets driven straight away to the abortion clinic. So we know how technology can be misused really, really fast, and we are in a dangerous situation that way. We have not had time to digest the technology. So yes, we have to look at the benefit. The benefit of who is the next question. Is it the benefit of the family? Yes. Benefit of the mother? Yes. Benefit of the fetus? Yes. But right now, that seems to be the last. And as clinicians, like as pediatric surgeons, if we are not involved, sometimes it's not our fault. If we are not involved, then it becomes a purely technological situation wherein someone sees and someone shoots, and we don't even have a chance to intervene. I've got patients who unilateral hydronephrosis who were advised abortion, who luckily did not go ahead with it because I think they took a call and now they're absolutely fine. But those are great ambassadors. And as you go along in your life, you will have patients like this. So I think it's good to keep their contacts and to build up a network of these parents so that they can support other parents when they come with these troubles. The room is awfully silent. Is everybody there?
Yes, sir. We are here.
Thank you. Thank you. This is like suddenly I felt I was talking to my screen. Yeah. Right. So, and then of course, then comes the concept of justice. Now, the justice here again is a very, very difficult concept to to understand, because even legally, if you go into for the newborn baby, the justice depends on the age of the fetus. Why do I say that? Suppose you have an anomaly and the fetus is still early in gestation, it's just in this early second gestation, it's a minor anomaly, but then you have the choice of aborting the baby, because legally it is okay to abort. Now, as of now, it may change now. If you get a really serious anomaly, and if you're aborting and want to abort and your child is beyond 21, 22, 23, then a lot of people are going to hesitate. So actually, the child with the milder anomaly lost life because of his age, whereas the older fetus, when diagnosis was made, has survived because he could not be aborted on a legal basis. Now, this is an unfair anomaly. It's an anomaly in the system if you look at it purely from a judicial point of view, because you're not saying justice is for all. You're saying justice is if you are less than this age. If you are more than this age, your judgment is different. Again, the reason for highlighting it is because there is no right answer in any of these four concepts when it comes to fetal counseling. But just to highlight for us how confusing it can be in every sphere of decision making. And this is where it is unfair. It is quite unfair. This is where we have a lot of place to catch up. And that is where I want to leave you confused. Remember, the fact is that it's all a gray zone. There is no black and white when it comes to fetal counseling, especially when we get excited with the few talks that we've had recently where the technology is beautiful. All right. So coming now, how is this going to help you as clinicians, as pediatric surgeons? There are three sides to this coin. The first side is that you're looking at optimizing the well-being of the pregnant woman. That takes precedence. That is because she is still the primary client for us in this when it comes to this, especially when the radiologist or gynecologist is the front person who started the counseling. The primary beneficiary should still remain the pregnant woman. On the other side of the coin is where we are directly involved, is the optimizing the well-being of the fetus. What we need is, right now sometimes it becomes a battle between these two boxes, them fighting for the pregnant woman and for the family, and probably we speaking up too much for the fetus, saying, and you will find yourself doing this, especially if you see more and more patients, especially with the slightly minor anomalies, if you can call them that, and you know that they're going to abort the baby. You're in a battle. You are in a battle. You are giving them a lot of contrary information. What will work is only an intermediate strategy, which balances both the interests. And how can that happen? Only by collaborating, talking, sharing, and listening to the other specialty, engaging with the other specialty. Because if we don't engage, they only see one side of that anomaly. Remember, I'm not being disrespectful, but remember, a gynecologist making a decision about the kidney management in a fetus sounds unreal, but unfortunately, that's what happens. A gynecologist taking a decision on hydrocephalus spina bifida alone, because they've done some fellowship degree, is a lot more dangerous than by doing it as a team. That is where I think most places now have a team wherein there is always a pediatric surgeon involved, and that is where you will come in your practice as well, to keep engaging. There is no point saying that that they are doing it. That I've learned as I've grown older. It's better to engage with them and to keep hammering it. And I think change in this comes very slowly. I think that is the battle that we have. Ramesh, what do you think?
I'm listening. Go ahead. I'll talk to you later. There are lots of Pandora's boxes you're opening, not just one.
Yes, I know. And I said I want to leave as soon as the presentation is over, so Ramesh will continue the conversation.
I want you to be there, but anyway.
I know. So continuing. Yeah. So what I want to now take on to is what is this non-directive counseling? When we counsel a patient, as a surgeon or as any medical person, especially you and me, when we see a hernia, I'll take it to a very simple clinical example. When we see an inguinal hernia in a child, our counseling is very clear. Our counseling is, this is the problem. This is the only solution. We have to do it. Which is all correct. It is absolutely right. There is nothing wrong in that at all. And that is the counseling that we are used to. This is directive counseling. It means you're saying, this is the road, we have to go down, we will go down this road. Otherwise, go see somebody else. Right? So this becomes natural for us, and this is correct. But when it comes to antenatal counseling, when it comes to an anomaly, it cannot be this directive counseling. And that is very hard for us to learn, especially since we spent at least, I've spent now 30 years doing directive counseling, saying this has to be operated, this doesn't have to be operated, where you're giving direction to the patient. When it comes to this, the concept is of a non-directive counseling. Non-directive counseling, we don't learn, but genetic counseling, though if you have friends who do genetic counseling, if you have people in your hospital, if you just spend 1-2 sessions with them when they are counseling, their counseling is very, very, very different. So they are not going down a direction path. This is a totally different counseling. And I find it very hard to even think that I can do that, because they are saying, this is option A, this is option B, this is option C, this is option D. They give them all the options and leave the parent to decide, leave the family to decide. You and I cannot do that for our clinical work. For clinical work, it has to remain directive. But for antenatal, unfortunately, a lot of our radiologists or fetal medicine or surgeons end up giving direct counseling. This anomaly is there. This is how it is going to end out. This is your option. Let us do this. Right? And that is where it becomes a Pandora's box, as Ramesh was saying. So just if you want to get on with your practice, if you want to hone your skill in this, take an hour or two, go to a friend who's a genetic counselor and just sit and watch. It's a completely different game. It's like learning to play chess and learning to play Ludo. Right? We are very good chess players, but this is a different game. So it's good to watch the game, not to use the same counseling principle. So the word I want you to remember today is to be non-directive when it comes to antenatal counseling. Now, the next thing which happens is when it comes to counseling in the prenatal period is that you are deciding for the woman, right? The woman is the primary patient, as we already said, in their best interest. But the best interest is in apostrophe commas. This is again a very nice publication. Read it up later when I send the link. Because when they say who decides the best interest, because best interest can be defined by, depending on who is talking and for whose interest it is, right? Whose benefit are we talking about? And also the boundary between, especially in our country, we know, but everywhere in the world, between choice and coercion, especially when it comes to antenatal counseling, is very, very blurry. There is no clear-cut black and white saying, okay, you have a choice, choose this. The patient is still going to wait for your next sentence saying, yeah, doctor, but what do you say? Yeah. So, and then if I'm sitting on a pedestal where there is also financial benefit for me, then my whole counseling is different because we're all human beings. Yeah. And therefore, this boundary between making a choice independently, which we are encouraging the patient to do, becomes like a dream. It becomes like a fairy tale. And actually, it becomes coercion because directive, you're giving the direction, you're providing the wherewithal, you're leading them where you want them to go. And specifically in antenatal counseling, that is a time bomb. That is very sad. I'll give you an example. Okay. So this was a baby in the UK. In the UK, in the early days of antenatal diagnosis, wherein there was a diaphragmatic hernia which was picked up antenatally and Dorman Street. And they went ahead after a lot of counseling and everything. All was good. They gave them all the treatment options. They chose to go ahead with the pregnancy. And one of the early ones where antenatal diagnosis was followed up, child was operated, and child was fine. It was a beautiful story. There was nothing wrong medically. There was nothing wrong surgically. Child was discharged, and the BBC took up a big interview with that family because it was a good human interest story. When it came to the interview on air, the mother, with all the good result and everything had gone very well for them, she said that during the entire journey of the antenatal period, she felt that she had no choice. And they went back and looked at the counseling notes. Everything seemed picture perfect. She was given choices, she was giving options. But then she confessed later that at that point in her pregnant state, one, two, being judged by her family, being judged by her by the doctor, she felt judged. Yeah, that they're giving me the option to kill the baby or to continue with the pregnancy. What will they think if I say no? What will they think if I say yes? And so, such a good result. That means you had diagnosis, you had treatment, you had no problem. She was in a place where she went and she said, I felt that I was coerced into it. I felt I had no choice. You and I will not even think that coercion was an entity in this kind of case, but there it is. And she was being very honest, and that I think is an eye opener for us. Even when I'm counseling, I'm very happy sometimes saying, okay, fine, I convinced this patient, everything is fine. But we don't know where we may be inducing a sense of guilt into the mother or the father or the family, one way or the other, especially for antenatal. We're not talking about the other counselings. In antenatal counseling, we have to constantly watch our back, to be behind our selves, keep looking over our shoulder, saying, is it possible that we are missing something? And then, so when they asked her, what would you have liked? She said, I might have liked them asking me one-on-one if this was there, because the counseling was done as a family. So she felt the social pressure of the family, and therefore she felt that she had no choice, even though she had a great result. Can you imagine what would have happened if there was not a good result? Anyone wants to intervene at this point? Any students, anybody want to discuss this before we go on? This particular thing.
Yeah, a few things I wanted to tell Robert. I don't know. Let the PG start and then I'll start.
Yeah. You and I will talk later.
No. I had for everybody's benefit also. Don't worry.
I know.
I think Ramchandra sir, Gopal.
Yeah, Robert, can you hear me?
Yes, sir.
Yeah, basically what you are talking about is the concept of maternal altruism.
Yes, coming, sir. That's the next
So
one.
if
Yeah.
you look at the our Kannada story of the legend of Punyakoti. Punyakoti is the cow who was accosted by
Tiger.
the tiger in the forest, and then she gives the word to the tiger that I will come back and give myself to you. I have to go to this thing. So that is maternal altruism. So I think we cannot go around it. Maternal altruism will be there in our society as long as I think that is another aspect of ethics, maternal altruism. So I think what you are suggesting is that you probably have to overshadow maternal altruism by being paternalistic. Paternalistic is now considered negative, but in cases of this prenatal counseling, I think there is a role for being paternalistic. Like, you have to be sort of above all these things and tell them, no, this mother cannot go through this procedure at this point of time, even if the mother wants to this to happen. So you have to be paternalistic and rule out this procedure. So that is sort of another aspect of the ethics where paternalism has to come in, overruling maternal altruism. That's what I feel.
Correct, sir.
What do you think? What do you think?
You went directly into my next slide. You went straight to my next slide because altruism and others was what was my next point. And you're absolutely right. And Punyakoti is easily one of the best examples because she was willing to sacrifice herself for that the baby. And this is well documented and known in pregnancy. Because one is the fact that it's the altruism. Altruism basically for the PG that you feel completely overwhelmed by wanting to do good for the baby that you will kill yourself. That you will take whatever harm comes your way, and you will agree for whatever is being suggested to you because you want to do the good. And that is a really genuine feeling. The same woman, when she is not pregnant, may not make that decision. But the pregnancy itself alters her decision-making ability in a good way, but it may not be the good which is good for her, good for society. It is very hard to get around. Like you sir said, you can't work out of altruism. Altruism is biological. It is engineered in the pregnant woman. It is something which happens during pregnancy. And so to keep that in mind, along with this comes the feeling of guilt. A lot of the times, especially in my practice, I'm sure it's the same for everyone. Halfway through, I stop everything and I have to just say, it is not your fault. It is not your genetics fault. It's not the father's fault. It is nobody's fault. And then they start crying. That is what they are sitting with. The guilt is what is paramount there, especially when it's a child with an anomaly. Maybe a smallest of anomaly. But the mother is constantly thinking, what did I do wrong? Hello?
Yeah, especially in posterior valve. You should tell them that the father is responsible for the posterior valve. Isn't it? I mean, when you look back at it, he contributed the Y chromosome and he contributed the androgenic status of the baby. So the posterior valve is entirely due to the father. The mother has no role in it at all. That's what I feel.
Correct.
That's a good one.
That's a good point. That's a good one. I haven't tried.
Absolutely. When it comes to that, sometimes I tell them postnatally when they come. I tell when the mother feels very guilty, I tell her that this is Y chromosome related and you have no role in this at all. The Y chromosome was contributed by the father of the child. So just be quiet. Just chill. Okay.
Yeah. So there, one is the feeling of guilt, which is overwhelming. And then along with that comes the desire to say, let me make this right. Let me correct it. And if you go back to that BBC story, this is what was there. That fact that she wanted to make things right for the baby guided her during her pregnancy time. When the pregnancy was over, the altruistic phenomenon reduced. And though she had a perfectly good result, the logical woman there said, hey, but I didn't have a choice to do this. I felt coerced to do it. And that is what it is not that she's lying. It is just that she's a different person and she's not pregnant. And therefore, we have to look at both sides. Like sir said, you have to keep the the family's expectations also together and realize we are not only counseling the mother, and she is coming into the room with a lot of guilt. And it is for us to be sensitive about that guilt. And I think just acknowledging it in front of the in-laws and the father makes a big difference. The fact that you are saying that it is not your fault. And I think this we should learn, especially as youngsters, I'm telling you. This I think it is our duty to tell that family, to tell that child, that mother, that it's not her fault, no matter what the etiology is. It doesn't matter. Yeah. Then there is another conundrum, another gray area which is there, which is this therapeutic misconception. This we are all aware. This has nothing to do only with prenatal counseling. If there's a new drug on trial, like we're seeing now for corona even, if there's a new drug which has come, and if Oxford is suggesting it, if it's an Oxford trial, we assume that it's going to work because it's being offered by such a big center. Oh, they're having a very good protocol, so it must be very good. And BBC is covering it, CNN is covering it, Donald Trump is talking about it. And this is a known concept, therapeutic misconception, where the misconception is that just because it's looking good in a protocol, or it's coming from a very big study center, it's coming from Indira Gandhi Center, or the news media is beating in every day they're going on about a particular drug. Take hydroxychloroquine, for instance. Yeah, so that itself leads to an assumption, especially when we work in big institutions. If you work in a metro city like Bangalore, most of our patients are coming from the smaller towns or from the villages, and they are coming in with that concept. They're saying we are going to the Mecca, we are going to a big hospital, dot hospital. I'm sure they mean, that's why they say nive heli. And this one especially is for our practical work which we do, not fetal counseling. For our other surgical work, this fits in fine. This absolutely fits in fine. If they're coming to a center where they're doing liver transplants day in and day out, it actually works. That yes, they are in that center and things will go better than somewhere else. But when it comes to fetal counseling, it is a complete gray zone again, because just because it's a big center or is a big name on the board or has many illustrious publications and it's coming up in the news media and TV, in terms of fetal counseling, it is again a disaster, an absolute disaster. And this is another beautiful article. This one compared the attitudes of obstetricians and gynecologists in fetal care medicine, compared it to the attitudes of pediatricians from the committee of American Academy of Pediatrics Bioethics Committee. It's a beautiful article because it just shows you for the same anomaly how much of a conceptual difference is there between the specialty you are coming from, right? And I have not put those slides today because I wanted it to be a shorter talk. Hi, Gopal. Thank you for setting me on this journey. It was Dr. Gopal from Warangal who started me on this journey because he's the one who pushed for this topic many years ago. But in those articles, we saw that OBG, when they do fetal ultrasound for fetal weight monitoring, and then they monitored it postnatally, there is about a 25 to 30% mismatch between what is estimated and what it really is. Yeah. So then some of the philosophers in the OBG circles itself said, hey, if we are misjudging a simple thing like weight of the fetus, how much more we must be misjudging organs which are being analyzed, because weight is a very crude parameter and there is a learning curve there itself. So when it comes to complex malformations, it is even more important to be skeptical. That is what even they would say. So skepticism comes from the patient, the therapeutic misconception, and from our own selves, depending on who is talking. If you listen to a fetal medicine person talking about hydronephrosis, and if you hear a pediatric surgeon talking about hydronephrosis, you will imagine that you're talking about two different diseases because our viewpoints are so different, right? Yeah, so this is what I was saying. So
we have short of time. In case it shuts down, we'll just relaunch.
Yeah, I'm almost done. Yeah. So when it comes to informed consent in the prenatal period, again, we know informed consent, you give all the options. And when it comes here, remember, it is not just the parental understanding, but by the physician's own understanding. If a pediatric surgeon is counseling that, is totally different, like we said, from a fetal medicine person counseling that. Not because they are bad or that we are bad. It's just that we are different. And our understanding is different. And patients will only take what we give them from our understanding, which is why we have to go back to that thing of non-directive counseling. We should hold ourselves back from giving direction. and restrict ourselves to giving information like the genetics people do, which is not easy. Which, no matter how senior we are, we have to go and learn this new skill at least a little bit. Now, listening to all this prenatal counseling, they're going to all these scan places, then they may believe that there are two options. One is success, which means fetal cure, my baby is cured completely, or failure, which means my baby died. But actually, in reality, there are four options. Right? There is a very big thing that point number 2, postnatal therapy, is where you and I come in. Pediatric surgeons, that is our work. If point number 2 is not there, we don't have any work. But that is not something which the parents will be too aware of. So at least for most of the anomalies, the fact is to be made aware of all four. If it is a correctable anomaly, we have postnatal therapy. If it is a non-correctable, it is a complex thing which you can't do much to, there is still palliation which is possible. And of course, termination is there if in the appropriate circumstance of timing and of severity of anomaly. But frequently what happens is success and failure is measured in terms of, okay, cure agutta, or will the baby die?